Good evening, everyone. Welcome back to You and Your Health. Thank you for joining our program this evening. My name is Erika Roberts, a co-host of this program, and my other co-host is Dr. Edward Isuman. Dr. Eddie, are you there?
Yeah, I'm here.
Hi, Dr. Eddie. How are you?
I'm good, and you?
Fine, thank you. Fine, thank you. It's
What's the
getting
secret behind your smiles?
um, it's probably from my lighting,
Oh,
the
okay.
lighting we just talked about, but I'm glad for yes, Dr. Teresa Finn to be
Yeah,
back to our program, and we're grateful that she accepted our invitation on a short notice to talk about a topic that is very prevalent. Gestational diabetes is very prevalent around the world.
and I want to say that there's no dull moment with Dr. Teresa. So we are
Yes,
going to have a lot of educative information from her.
yes, yes,
Mhm.
yes, especially about this topic. So I'm
Yeah.
excited to have her back. So we just go ahead and get started because we're already like 4 minutes in. So before we get started, we'd like to thank our previous guest, Dr. Barbara Insua, for her excellent discussion on cervical cancer. As I mentioned, cervical cancer is among the many topics in Dr. Insua's book, A Woman's Guide to Her Health. And so if you are interested in her book, in the book, you can either get one from myself or Auntie Jane or Dr. Eddie. This is the book. I kind of have it over here. This is the book. They sell it on Amazon, but if you do get it from one of us, it will be cheaper. So hopefully you all will be interested in it. And if you have not watched the segment on cervical cancer, we suggest that you do so. She provided a lot of information. And it's on the church's Facebook webpage and also on YouTube as well. And please feel free to forward it to others. So now we're going to get started on this evening's discussion on gestational diabetes. Gestational diabetes, as I mentioned, is very prevalent all over the world. Every year, 2% to 10% of pregnancies in the United States are affected by gestational diabetes. So again, we're glad that Dr. Finn was here to discuss it with us. Managing gestational diabetes will help make um, the pregnant women, the mothers, have a healthy life as well as the baby as well, and prevent future potentially developing type 2 diabetes. So we are grateful for her to come. As I mentioned, Dr. Finn is a board certified internal medicine physician and an endocrinologist at Premier Endocrinology in St. Cloud, Florida. Dr. Finn completed her undergraduate studies and finished her medical schooling at the University of Ghana School of Medicine and Dentistry. She then completed her residency in internal medicine and a fellowship in endocrinology, both at Howard University, Washington, D.C. She is known to treat patients with complex medical issues, including obesity, lipid disorders, and osteoporosis, among others, chronic conditions. Not only is she the president of Premier Endocrinology, she's also an assistant professor of internal medicine at the University of Central Florida. She's an active member of the American Thyroid Association and the American Association of Clinical Endocrinologists. So we are very grateful that she's back with us again. So let us welcome back Dr. Teresa Finn.
Thank you very much.
Thanks for coming back, Dr. Finn.
Thank you. Thank you for having me, Rico and Eddie.
Yeah, you're welcome.
So we're thinking about saying, what other topic that can Dr. Finn discuss with us? And I was like, gestational diabetes. And that's something that, women, as I indicated, all over the world get. I think back home, they just use the word diabetes without differentiating whether it's gestational diabetes or type 1 or type 2, just the person has diabetes. So it's just great that you are able to come back and to, shed light on the topic, and hopefully our viewers will be inspired to learn something about it. I think we have a lot of uh, age group that could have children in our church, and I know that's something, the topic that it's important for them to be
Yeah,
aware of.
yeah, and I know it's a topic that most women would also relate to. So I think
Mhm.
your audience would be pleased and would be very interactive as well.
Okay,
Yeah.
thank you.
So if you're ready to start, and Dr. Eddie can go go ahead and project your slides. And are we able to like interrupt and ask you questions in between, or?
Okay. Am I ready to start, or Eddie, you're going to make it big, like a slideshow?
Eddie, are you able to do that?
Mm-hmm. Okay, so thank you very much for having me. Thank you for the warm welcome. I'm very happy to be here. I want this to be as interactive as possible, so you can stop me anytime. I don't have a lot of slides because I want to rather answer a lot more questions. So my name is Theresa Finn. I'm an endocrinologist in the Central Florida area, and I'm part of faculty at the UCF, University of Central Florida. So today I'll be talking about gestational diabetes. Eddie, we can move to the next slide. The question is, what is gestational diabetes? Basically, it's the term that we use to describe diabetes in patients who are pregnant. But there always has to be a distinction between the one who had diabetes before pregnancy but did not have a clue about it, and the one who has developed diabetes as a result of pregnancy. And so for the most part, most women will see an obstetrician somewhere around 5 to 8 weeks of pregnancy when they've missed their last menstrual cycle. So at that time, they are well into the first trimester. And so it's very important that the obstetrician pays attention to the risk factors, like a patient who has had previous gestational diabetes, a patient who is obese, a patient who is older than 25. These are all risk factors that usually greater than 40, absolutely you have to screen at the time they come for their first visit. But for the rest of the patient population, unless they have these risk factors, they are not usually screened for diabetes at that first trimester.
So I have a quick question. How about patients with polycystic ovary syndrome?
Yes. So patients with comorbidities, the metabolic syndrome, polycystic ovarian syndrome, chronic use of steroids, these are patients who are already at risk for diabetes. So when somebody with PCOS comes to see you, you can see the darkening in the back of the neck, what we call acanthosis nigricans. You as an obstetrician should screen for diabetes. If the patient tells you that my last pregnancy, I had diabetes, I was on insulin, and then it went away, but I never followed up, and now I'm pregnant within a year since the last pregnancy, you have to screen because maybe they are still diabetic, but they don't know. And I think it's on my other slide, so we can move forward and I'll talk about that. So in pregnancy, we release these hormones that helps the placenta to stay attached to the lining of the uterus and help the baby grow. Unfortunately, these hormones are also very diabetogenic. When I say diabetogenic, that means that they make it more difficult for the body to utilize insulin. Insulin is produced from the pancreas. So if you already have a patient who is in the pre-diabetic state or is already losing the ability to produce insulin, then pregnancy will immediately predispose them to a state of insulin resistance. Because let's say the pancreas, the normal pancreas makes 100 units of insulin a day. And you have a patient walking around with maybe 75% production a day. You need 50% production to call them diabetic. And then they they become pregnant. They're releasing all these hormones that is making it more difficult for the 75% to work. You are going to pick up diabetes in these patients. They are at high risk. So again, that comes to what the polycystic ovarian syndrome, patients on chronic steroid therapy, patients with Cushing's syndrome, which is an adrenal tumor producing excess cortisol. Hopefully Cushing's will not fall pregnant, but if they do, then you have to pay attention to that.
So if someone have had, and I think obviously you have on here previous pregnancies, who may have had gestational diabetes with their prior pregnancy, but what if they didn't have it but also had a child that was like 9 pounds or greater?
Yeah. So those are the risk factors. Those are the risk factors. And I think I have it in the later slides. Okay. So there's some risk factors that you have to look at. And yes, multiple gestation, somebody who is on their fifth pregnancy, fourth pregnancy, they're at risk. Somebody who's had a child who's greater than 9 pounds, even without a diagnosis of diabetes, you have to suspect gestational diabetes, because remember, gestational diabetes can be treated with medications or just diet and lifestyle. So some patients may never go on insulin, may never require medications, but they had it. And depending on the antenatal care, most women do not really go for antenatal care, especially in the minority population. So unfortunately, these patients are going like for months through their pregnancy without having been screened for diabetes. Okay. Okay, we can go to the next slide. So what is the prevalence? The prevalence of gestational diabetes traditionally in the US is about 6%. So 6% of the women who fall pregnant in the US will develop gestational diabetes. Worldwide, it's about 2 to 38. I was wondering why is such a discrepancy? I said, oh yeah, Africa is underreporting, so 2%. And then obviously among the racial and ethnic groups, so generally Hispanics, Hispanic Islanders, Native Americans, African Americans, very high risk for developing diabetes as opposed to the Caucasians. Next slide, we can go to the next slide. So what are the risk factors? That's what we're talking about. Any woman who developed gestational diabetes, and any women who are at highest risk are those above the age of 25. So that's pretty much almost the entire reproductive age group. The younger patients have their own risk factors. Like if you have a child at 16, they are more at risk for preeclampsia, which is elevated blood pressure with proteins in the urine, etc. Then family history. If somebody has a family history of diabetes and also gestational diabetes, you have to think about gestational diabetes. Their risk factors are high. Obesity, people with a BMI greater than 30. We should all know what our BMI is. It's simple. You go on Google, you put in BMI, body mass index, and anything above 30 is considered obesity. There are different stages of categories of obesity. Obesity class 1, class 2, class 3. Class 3 is morbid obesity. Normally their BMI is above 40. Those are very high risk patients. And then obviously any mother who had gestational diabetes in a previous pregnancy or had a childbirth weight of greater than 9 pounds. Any mother who had a previous unexplained perinatal loss. So they went to term, delivered, and the baby died. Unexplained. You have to start thinking, was it gestational diabetes? Because sometimes they have malformed babies. There's a big name, polyhydramnios. Most of the time, if you go for proper antenatal care, at 20 weeks, they are going to pick up these congenital abnormalities, and they'll probably advise the mother whether to continue or terminate the pregnancy. I mean, because the baby will not survive outside the womb. Because you can have some serious malformations, like kidneys that don't work. You can have shrinking of the brain. Most of the time, it's neurological and renal for these. Yes, and it happens in patients, especially those undiagnosed diabetic. So remember that the first 8 weeks is when most of the major organs of the body are forming. Unfortunately, if they don't know they have diabetes to control it, then these mothers are going to really expose the fetus to high levels of glucose, which can lead to these congenital malformations.
So when should they test for gestational diabetes and pregnancy in terms of what weeks?
24 to 28 weeks is when we check. But the clinician should be aware of these high-risk patients and screen irrespective, because you may be dealing with a diabetic who is now pregnant, or somebody who doesn't know they have diabetes but is now pregnant. So it's important that you distinguish gestational from regular diabetes, type 2 diabetes, because gestational will go away after pregnancy. It's just the presence of those hormones that is, I mean, they are more at risk for developing for developing diabetes, but they would usually go away. But type 2 will not go away. If you have diabetes before pregnancy, it won't go away. It's going to stay. And then obviously, go ahead.
Now, I was going to say, I noticed that you had hypertension on the list as well. I was going to ask you whether gestational diabetes increases one risk of having high blood pressure during the pregnancy itself.
So gestational diabetes per se will not predispose you to hypertension, no. But somebody who has high blood pressure will normally have other risk factors like obesity. And so that can put them at high risk for developing gestational diabetes. But the fact that we have a lot of diabetics who don't have high blood pressure. So the fact that you have diabetes does not mean that you have high blood pressure. But then the presence of hypertension with the other risk factors predisposes these patients to developing gestational diabetes. Those with cardiovascular disease, most of the time they are talking about the coronary artery disease, the diseases that they have to put stents, the ones that we call heart attack, not the valvular diseases, not the arrhythmias. Those are more like structural heart disease. We're talking about the diseases that affect the blood vessels. And then acanthosis nigricans, again, is the darkening at the back of the neck. Some patients have darkening in the underarm. Yeah. Some patients have darkening in the underarms. It's important. When you see darkening at the back of the neck, it's not that they are not taking a shower properly. It's actually a sign of insulin resistance. And if somebody tells you, because we don't see our back, so if somebody tells you, hey, you have this darkening in the back of the neck, you need to pay attention, speak to your doctor, and get screened for diabetes because it precedes diabetes. Okay. So we can go to the next slide. Now, prevention. How do we prevent gestational diabetes? So now you know you have a BMI of 30, you have polycystic ovarian syndrome, you have high blood pressure, you have cardiovascular disease, or you just have a BMI above 30. What are you going to do before you plan your pregnancy? You try and get your weight down. So in patients who are overweight or obese, weight loss before the pregnancy alone can reduce their risk of developing gestational diabetes significantly. And then during the pregnancy, that diet and exercise program should continue. You don't stop. And even continue past the pregnancy so that you don't develop. So it's not like you're going to try and lose weight, then you fall pregnant, you eat everything, relax, you can develop gestational diabetes. So it should be an ongoing process. Now, when we say weight loss, then we are talking about portion control. Try not to eat late at night. Dinner should be by 6, 7 p.m. latest. Count your carbohydrates. I think we talked about this in the diabetes program. But basically, portion control. We normally recommend 60 grams of carbohydrate for men, but we are not talking about men here, and 45 for women. 45 grams of carbohydrate for women. For snacks, should be less than 15 grams. And these things, they seem arbitrary, but they're very easy. If you get a food diary and write down everything you would normally eat for breakfast, for lunch, for dinner, and you go on Google and Google how many carbohydrates are in a slice of kenke, how many carbohydrates are in a piece of yam. It's all on Google. And then you can really limit it to 45 grams of carbs per meal. Because seeing a nutritionist in the US can sometimes be difficult for those patients who eat traditional meals and not the usual American diet. Because most nutritionists are not familiar with your diet. So you're sitting in front of a nutritionist who is advising you to eat foods that you normally don't eat. So it's very important that you do the homework yourself so that you can try and attain this weight. I think that anybody in the reproductive age group should try and lose the weight so they don't put themselves at risk.
So question. So when someone is pregnant, we recommend them to continue to lose weight or just maintain the healthy diet that they've started, but not necessarily trying to lose weight.
Yes.
Because they want you to maintain your weight too while you're pregnant.
Because don't forget that in pregnancy, generally women will gain weight, but you don't want to gain too much from overeating too. So you want to maintain. If you're on a 45 grams of carbs per meal diet, then you just continue that. That's enough maintenance diet for you and your baby. So you're not really starving yourself. Some people say, I have to eat for 2. Babies are parasites. They will eat irrespective. They will eat irrespective. So it's important. At least 30 to 60 minutes of exercise 3 to 4 times a week is very good for your health. Outside pregnancy, during pregnancy, and post-pregnancy. So that, especially when you know you have the risk factors. Some patients are very thin. They have no family history of diabetes. Their BMI is great. They eat everything under the sun. They're not going to develop gestational diabetes. But if you know you have the risk factors, polycystic ovarian syndrome, you're obese, your BMI is about 30, you have other risk factors, hypertension, cardiovascular disease, you've been on steroids for prednisone, for asthma, on and off for several years. All those patients are at risk for gestational diabetes. And so it's very important that you control what you can prevent, and then what you can't prevent, which is pregnancy, you just go through it. But at least your weight you can prevent.
So is it automatic that someone with gestational diabetes will have a large baby?
If they are in control.
It's a fact. Okay. And then also, how about in terms of delivery? Because you read that, if you have gestational diabetes, you're most likely going to have cesarean delivery. Do you think that's always the case, or?
No, that's not always the case.
Okay.
I have some patients who have type 1 diabetes in pregnancy, and they're able to keep their sugars so well controlled. They're just like anybody without diabetes. They go through a normal pregnancy, smooth sailing. They keep their sugars under control, tightly under control. You have some patients who develop gestational diabetes. Once you control the sugars, there's no sugar for the baby to feed and grow big. So that baby is not going to grow big. But when you have so much sugar sitting in your bloodstream, then you're going to have a big baby. So once you control the sugars and you're under very good obstetric care, so those patients have to be under the care of preferably a high-risk obstetrician. And if you can find an endocrinologist who is comfortable managing diabetics in pregnancy, absolutely, then you should, and then obviously a nutritionist. So it has to be like a team approach.
All right. So these two questions come in, and I wanted to put it across before you move on.
Sure.
So every woman wants to give birth to a larger baby. So why would I not give birth to a larger baby when I have gestational diabetes?
You see, what is a larger baby? A larger baby, let me tell you, those fat babies,
Subjective.
those big babies that you see, they're very unhealthy. Those babies can just die. When you give birth to more than 9 pounds baby as a result of gestational diabetes, apart from the obstetric risk during the peripartum, so during the time that you're going to actually push the baby out, if it's going to be C-section or it's going to be a large baby who gets stuck, hopefully that will not happen because you have a good obstetrician who is watching what's going on. But you can have fetal distress from prolonged labor, and you're rushing these patients into the operating room. The patients are suddenly at risk for hypoglycemia, the babies, because remember, they've been exposed to so much sugar that their pancreas is producing so much insulin. And then suddenly you take them out of the womb, there's no more sugar. But the pancreas is still making the insulin. So they get hypoglycemic. They can have electrolyte abnormalities like hypocalcemia. They can also have respiratory issues. Very, very common among babies born to gestational diabetic moms. They have the most respiratory issues during the perinatal, around the time of delivery. So they may be the ones who may get intubated. Very nice, chubby baby, but she's on the vent. So those babies are not healthy at all. And don't forget that 50% of babies born to gestational diabetics will themselves become adults with diabetes.
Yeah.
So they are the highest risk for developing diabetes.
Yeah.
So you don't want to have gestational diabetes, but if you do, that is the one child that you want to keep skinny for the rest of their life. Because they're so at risk for developing diabetes.
Right. You're prone to be obese.
Yeah. Yes.
And another one is she's saying that all women with gestational diabetes will not have diabetes once their baby is born. So why the need for go for checkup or
because of these. So you see, the good news about gestational diabetes is that most of the time, once you take the baby out, the placenta is gone and the hormone levels drop. Within 72 hours to a week, they don't have the diabetes anymore. Are they at risk for long-term development of diabetes? Yes, they are. If they don't do the right thing, within 5 years, 50% of those women will develop diabetes.
I was just about to say that. That's what CDC says, 50% would develop type 2 diabetes.
So they are at risk for developing diabetes with all its complications. And then you're also talking about a pregnancy that suddenly becomes high risk. Because if these patients are on insulin, sometimes we have to put them on insulin to manage the sugars. Sometimes we may have to put them on oral medications, or sometimes just diet, those who are very mild disease. So it's important that we control the diabetes. Absolutely. It's like saying that, oh, if I have preeclampsia, once I give birth, it will go away. So why can't I have preeclampsia? You can die having preeclampsia. You can die with gestational diabetes.
Yeah.
Okay, your take on the perception that only overweight women develop gestational diabetes?
Not necessarily, no. Because remember, there are so many predisposing factors. We have patients with polycystic ovarian syndrome who are skinny. But polycystic ovarian syndrome, for those who don't know what PCOS is, Polycystic ovarian syndrome is a condition where a woman has too much male hormones, and so they develop a lot of abnormal hair distribution, irregular menstrual cycles, and cysts in the ovaries. To make the diagnosis, you need 2 of 3 or 3 of 3. Any of these 2 I mentioned or 3 I mentioned is a clinical diagnosis, suggests that these patients have polycystic ovarian syndrome. These patients, irrespective of their BMI, they are at risk, very high risk for developing diabetes. So
Or
it's not,
age too.
yes. So it's not just being obese. I mean, obesity comes with its own issues. We all know about it. But I'm telling you, most of the unhealthy people I know in this world are skinny. And so sometimes it's just lifestyle modification, really paying attention to what you do, eating right, exercising, sleeping well. That kind of thing helps.
Okay.
Mhm.
All right. I'll come back with more questions later.
Okay.
Okay, I guess you can go to the next slide.
So we can go to the next slide. Mhm. So how do we diagnose gestational diabetes? So it's at between 24 and 28 weeks. So remember, if we diagnose you before in the first trimester, then you had diabetes before pregnancy. So you'll be treated as diabetic in pregnancy. Gestational diabetes within 24, as the pregnancy progresses, your risk for developing gestational diabetes increases. So we have a 2-step approach or a 1-step approach. So your doctor is going to tell you everybody's going to be screened for this. So the 1-step approach, you give the patient 75 grams of a glucose. It's almost like a syrup to drink. And then they'll check their sugars 1 hour and 2 hours later. And then we have that's a 2-hour 75-gram oral glucose tolerance test. Then we have the 2-step approach where you give them less, because sometimes when patients are drinking the 75 grams, some of them hate it so much, they say it tastes horrible, and then they feel like vomiting. And if they vomit, then it doesn't work because you never drank it. So sometimes you may just do the 50 grams 1-hour glucose tolerance test. If it's above 135, that's a positive test. Then you have to go and do the screening test with the 3-hour glucose tolerance test, where you're giving them 100 grams, and then you check 1 hour, 2 hours, and 3 hours. If at the end of 3 hours they're above 140, they definitely have diabetes. If they're above 200, diabetes. And so that's how we screen. You can go to the next slide. I think I have more.
Yeah, the step 2 approach is difficult for patients, especially if they have hyperemesis. They have hyperemesis and they have to do that. It is very challenging for them.
Difficult. And they have to be fasting, and some of them have cravings. So it's difficult. So with the 3-hour tolerance, the normal blood sugar fasting is around 95. 1 hour after somebody has drunk the 100 grams, it should not go beyond 180. 2 hours, it shouldn't go beyond 155, and 3 hours, 140. So if it goes above these, if you get 2 or more higher than normal, then that's gestational diabetes. If it's just 1 that is abnormal, then you have to repeat the test. And then we can go to the next slide. For the 2-hour glucose tolerance test, that one, 140 to 199 is sort of the gray area where you're going to call the patient. I always say you are either pregnant or you're not pregnant. We don't say pre-pregnancy, so we can't say pre-diabetes. But unfortunately, there's something called pre-diabetes. So that means that you are impaired glucose tolerance. So you have some resistance, but you're not full-blown. So those patients, you could rescreen them, but they are high risk and you have to pay attention to them as well. And then if it's definitely above 200, then they have gestational diabetes. And then at that point, you're going to introduce lifestyle changes, which you do for any diabetic. You're going to give them a glucose meter. They have to check their sugars before the meal, sometimes 1 hour after the meal. I think it's a bit too much, but in an ideal world, you check your sugar fasting, then you check it every time before you eat, and then 1 hour after you eat, so that the doctor can look at the numbers. And you don't want to go beyond 140 1 hour after the meal, or 120 2 hours after the meal. And then obviously fasting glucose, you want to keep it. For diabetics, we keep them 60 to 90. So even when they are so-called low, because less than 70 is considered low, but 60 to 90 fasting is considered normal for pregnancy. And then you don't want them to go beyond 140. So if you can keep them in this range with lifestyle changes, which is eating right, counting the carbs, exercising, then absolutely, then it's working. If you do this and it doesn't work, the numbers are a little bit off, you can start them on oral medications. Fortunately, metformin can be used, glyburide can be used. These are the 2 oral medications we can use in pregnancy. You cannot use anything else. You can't use Jardiance and Jardi, any of those fancy drugs out there. They are not indicated in pregnancy. If those do not control the sugars, I usually bring them back 2 to 3 weeks, 2 to 3 weeks, 2 to 3 weeks, because you have to stay on top of it. If you don't stay on top of it, the baby is going to come out with a bad outcome. And sometimes as a clinician, that can be very painful because you see the mother throughout the pregnancy and you don't want a bad outcome. So tight glycemic control is very, very important. If that fails, then your next choice is going to be insulin. And it's going to be insulin 4 times a day. You're going to put them on long-acting insulin, and then you're going to put them on insulin with meals. And they're going to keep monitoring their blood sugars. You have to take your meter to the doctor. In pregnancy, if your doctor is not looking at your glucose meter, then you have to see either an endocrinologist or a high risk obstetrician, because they will look at it. It's very, very important.
Actually, they should keep a log of it for how long? So
throughout the pregnancy.
Throughout the pregnancy.
Throughout the pregnancy till to the end. So it's very important that we do this. A big number of the population are underdiagnosed. In the US, it's believed that 30% of the population are in the quote-unquote pre-diabetic range and don't even know about it. So there are different. American College of Obstetricians have their own guidelines. American Diabetes Association have their own guidelines. But basically the consensus is that if a patient is high risk with all these parameters I talked about, obesity, previous gestational diabetes, multiple gestation, polycystic ovarian syndrome, just screen them at the first visit. Make sure that you're not dealing with a diabetic from the get-go. And then if not, then wait till 24 to 28 weeks and screen them again for gestational diabetes.
So if you do see an endocrinologist, and should you insist on having seeing a dietitian as well?
Absolutely.
Because they don't always offer for you to do that. So
yeah. Some endocrinologists are not comfortable managing pregnant women with diabetes because they just don't want the liability. Because, with pregnancy, everything that happens in pregnancy, they have up to age 18 to come and sue a doctor. So people don't even want to be part of that whole process. So they'll be like, oh, go to the high-risk obstetrician. And the high-risk obstetrician is trained to manage diabetes in pregnancy, and they usually have a nutritionist. But some endocrinologists are comfortable. I manage all my diabetics in pregnancy because sometimes I feel like we do more for them because the obstetrician is looking at the baby, ultrasounds and all that. And then they have like 15 minutes to take care of you, and they have to look at your machine. But that's all we're doing. So for me, I'm more comfortable managing diabetes in pregnancy. But not all endocrinologists may be comfortable, and it's okay. High-risk obstetricians are very, very good, very skilled at this. Yeah.
So in terms of physical activity, being active, is this something that you will recommend they do, or is this something that like a brisk walking or anything that's like 30 to 60 minutes? Because you might do some activities that may be detrimental to their health in terms of physical activity. So it doesn't matter what they actually do in terms of exercising to help with their weight.
So when it comes to exercise, it is what your body dictates to you. So if you can walk for 10 minutes and you feel like, oh my God, I can't go anymore, you got to stop. Listen to your body. The next time, push it to 12 minutes, then 15 minutes. This is not the time to go and register with gym membership and do 1 hour Zumba when you've never exercised pre-pregnancy. No. So it's a gradual build-up. But as you keep doing it, I always say that walking is the best exercise. I'm telling you, if you walk for 30 minutes a day, that's all you need. People do the step. There's this thing called the step up. I use it all the time, and it's really helped me because sometimes you're so deconditioned. You're going up the stairs and you're panting. And you're like, oh my God, I've been working all this standing on my feet. But just the act of walking, and if you can do like 10,000 steps, it really makes a difference. But you have to stay true to it. Even when I finish today, after this presentation, I have to walk because I'm at 5,000 steps. So I have to walk 5,000 before I come back.
You're behind.
I'm behind. I'm at 5,000. So walking alone can do it. Nothing strenuous, as tolerable. And as the pregnancy progresses, obviously you're carrying another baby or two. So you want to take it easy, but keep going, as tolerable.
Okay.
Okay, we can go to the next
Yes.
slide. So we've talked about diagnosis. Let me see. Now, what are the short-term consequences? Somebody asked about, oh, it will go away after pregnancy, so what should I do? So when we say big babies, what does it mean? Babies who are 90th percentile for weight are considered big babies. Most of the time, they're greater than 9 pounds. And then the short-term consequences will be things like preeclampsia, gestational hypertension. Polyhydramnios means they have some abnormality. The baby has a fetal abnormality. You know, babies keep swallowing the amniotic fluid, which is the fluid around them in the uterus. So they keep swallowing that amniotic fluid and peeing it out, swallowing and peeing it out. When they have renal issues, they are not able to pee it out. So there's just a lot of fluid around the baby. And that excess amount of fluid can make the baby grow small so that you can have IUGR, intrauterine growth retardation, where the babies are not growing properly. And sometimes that can lead to early delivery. And then also the fetal abnormalities, brain, and sometimes these babies are born and they don't do well in school because of whatever happened in the uterus. And then stillbirth. You give birth to a baby, you could hear heart sounds, the baby comes out, baby is dead because of these congenital abnormalities. Preterm labor, they go into labor early because the uterus can stretch only as much and then it will trigger labor. But you have such a big baby at 26 weeks, it's like you're going into labor.
Like a full term.
Yeah. And then obviously the neonatal abnormalities I talked about, they come out looking very nice, crying, but they're hypoglycemic. They come out, sometimes they can have what we call a transient cardiomyopathy, which is enlargement of the heart of the baby. That will usually go away. But in the peripartum stage, it can sometimes lead to respiratory issues or even some cardiac issues where the baby is not able to breathe properly. So these are all the short-term complications. There are more of them. Obstetrical short-term complications. If you bring the pediatrician here, they'll give you a barrage. They'll be like, I don't want a gestational diabetic baby because they just don't do well. Very beautiful, nice, chubby looking kids, but they don't do well in the ICU. And the next slide. So the long-term complications will be a strong marker for development of diabetes in the mother and also in that child and in the offspring. And then also a poorly controlled maternal diabetic during pregnancy will affect the neurodevelopment of the child. So that's why I was saying that sometimes these children are born with neurological problems. Sometimes they don't do well in school. Sometimes they have speech problems. So these are all things that can happen just because you didn't keep your sugars under control during pregnancy. Okay, can go to the next slide. So how do you manage the pregnancy? I talked about the fasting glucose should be usually 60 to 90, average around 95. 1 hour after you eat, you don't want to go higher than 140. 2 hours after the meal, you don't want to go higher than 120. I have patients who have the sensor. The sensor is a continuous glucose monitor. It's not indicated in pregnancy, but there's nothing wrong with putting a monitor on your skin just to monitor your sugars. And they can see their blood sugars in real time. And so they can look at it 1 hour after the meal, 2 hours after the meal, make changes to their diet, or we can make changes to their insulin if they're on insulin. So we have so much technology out there to help these mothers so they don't have to just keep sticking their blood sugars all the time, where they're sticking before the meal, 1 hour after the meal, 2 hours after the meal. It's a lot. And so the sensors will help. Sensors, you will usually monitor the blood in the the glucose in the interstitial space. So definitely it's not as accurate as if you checked your blood, but it still gives you a difference of plus or minus 20 to 30. So at least it gives you an idea where you are in terms of blood sugar control.
Are these approved by most insurance companies or?
Insurance, don't start me. What do they pay for? Nothing. Apart from collecting. Normally, the indications, okay, most of these mothers are hopefully not Medicare, but some people have comorbidities, so they end up being on Medicare. Medicare has strict guidelines. It says you have to be insulin dependent. That means that you don't make insulin, type 1 diabetes to qualify for pump therapy. If you have any of these commercial insurances and you're taking insulin, you can make a case for it. We have the Freestyle Libre. It's so commonly used. Most of these commercial insurances will pay for it. It's not as expensive as Dexcom and Guardian Connect, which have all these regulations. And Freestyle Libre, even without insurance, most clinicians have it in, most endocrinologists have the sensors in their offices. They give it to us. They just don't give us the transmitters. So they give you the machine, and then you have to purchase the transmitter. So you put it on for two weeks. It stays on for 2 weeks, and you have to move it to a different site. And even if you did self-pay at any of these with GoodRx, etc., you may pay $70 a month. But if you go on Amazon, you can shop for something less. So if you want to invest in it, that's something you can go for if you want to pay for it. But if not, then you can get the commercial insurances to pay for it. But you're right, it's a challenge to get these products now.
Yeah.
It's a big challenge.
Yeah.
It's not a walkover at all.
Yeah.
Okay, we can go to the next slide. So management involves fetal surveillance. So that's going to be with obstetrician. They know what to do. Sometimes they are doing what they call a stress. Sometimes
Stress.
yeah, those tests they do with ultrasound towards the end of the pregnancy.
They call it monitoring the baby.
Oh, okay, I forgot all my obstetrics. So they do the fetal surveillance. Usually at 20 weeks. Yeah, at 20 weeks of gestation, all pregnancies, you should have what we call the anomaly scan, where you are doing a detailed ultrasound to see if there are any abnormalities of the baby. And sometimes this is where they may pick up these abnormalities and say, oh no, this must be a gestational diabetic. And then it triggers the screening for gestational diabetes. Weight management and tight glycemic control. That's going to be with a high-risk obstetrician, endocrinologist, or the nutritionist. And then obviously you look out for maternal complications like preeclampsia. You look out for preterm labor. You look out for sometimes even cardiomyopathies in the mothers. And then you can schedule delivery. Most of the time it's at 39 weeks. I think I have a slide after this. It's very busy. Let's see if I have that one there. Oh no, that's not on this one. Can we go to the next one? Let me see. Okay, so this is basically the summary of what you do. This is for the obstetrician. So uncomplicated, good control, when to do an ultrasound, try and deliver around 39 weeks. So this is very busy, but basically they have these strict guidelines that they follow. When they think that, oh no, this baby is growing too much, they're going to schedule a C-section and deliver the baby, obviously with the neonatologist, because we know that these babies come out and they look very nice, but they're also very high risk babies in the perinatal period. Okay.
I know it could be overwhelming because I worked at a facility that we saw patients in that condition, and they have to see an endocrinologist, they have to see maternal fetal medicine, they have to see the regular OB/GYN, and trying to kind of maintain a schedule for all of them becomes overwhelming. And then that's when you see patients missing appointments. Because maintaining that schedules is a very busy schedule, but you certainly have to do it if you're trying to keep healthy and then keep the baby healthy as well.
Yeah, absolutely. And most of the time when they see the high risk obstetrician, they really don't have to see the regular obstetrician. Or maybe they have to see them from time to time because they'll do the delivery.
Yeah.
They will do the delivery. But the high risk obstetrician, pretty much, if you get a very good one, you don't even have to see an endocrinologist. Some of them are really good. They manage pump patients, the diabetics with the pump, insulin pump, they manage it in pregnancy. Because obstetricians normally don't care for medicine at all.
Yeah.
But high risk, the maternal fetal MFM, maternal fetal medicine doctors, they are like medics in the obstetric field. So they do a lot of internal medicine. They understand valvular heart disease in pregnancy. They understand cardiomyopathies in pregnancy. So they're almost like medical doctors who are obstetricians. So they are very, very good doctors.
Yeah.
Very, very good doctors. So if you get one of those, a good one, they can pretty much manage the whole pregnancy. But whatever it is, make sure that doctor is looking at your glucose meter. If they're not looking at your glucose monitor, they are not good enough for you. Because that's the only way you're going to tell. In pregnancy, we don't do an A1C routinely. I do it just to have an idea where the patient is. But the hemoglobin A1C, that 3-month average thing, it's not very reliable in pregnancy because in pregnancy, we have volume overload. And we know that sometimes depending on the red blood cells, these values can be either extremely high or extremely low. We have so many things that affect the results of the A1C. So the glucose tolerance is all we have, and monitoring your blood sugars with your meter or your sensor. That's pretty much what we have. Okay, we can go to the next slide. So postpartum management, what do you do after the mother has delivered? Most women with gestational diabetes can resume a normal diet postpartum after delivery. Usually it's almost instantaneous. Everything just reverts back to normal, even before discharge. If not, if that doesn't happen, most women will see their obstetrician 6 weeks postpartum. And at that point, in an ideal world, if the patient still has, some of the patients will still be checking their sugars randomly. And if they tell you that the sugars are high, then that should be an opportunity to refer the patient for further management, that this may be progressing to diabetes. Because remember, gestational diabetes is supposed to go away, but some patients can develop diabetes after pregnancy that will never go away. That's different. The hormones are gone. You should not be diabetic. If you're diabetic, then you are truly diabetic type 2. So you screen for over diabetes if after 72 hours to a week, the patient, you can't take the patient off insulin or you can't take them off the pills. And then obviously every woman has to be screened for depression. These women have gone through a lot. They've gone through dealing with seeing a lot of doctors. They were healthy. They had no problems. They fall pregnant, through no fault of theirs. They produce all these hormones that makes them insulin resistant. Now some of them have to inject insulin 4 times a day. Some of them never heard about diabetes. Now they have to deal with all this. So some of them can go through depression. Remember, postpartum depression is real and we have to address it because these women, everybody is looking up to them to take care of the baby, but they themselves need taking care of. So postpartum depression is a very common thing among mothers with gestational diabetes, and we must pay attention to it and screen them for it as well.
And it could last for a while too. I think folks assume it goes away in a couple of months, but it could literally last for a year or longer, depending on what's going on within the household and the environment. So,
yeah. So what is the prognosis? Like I said, it goes away. Some patients, it may progress. If it does, you're now diabetic. It's important that we optimize the interpregnancy care so that we minimize these risk factors. So the interpregnancy care means that after you are told that, oh, the diabetes is gone away, continue to work on your weight and get your weight back to your pre-pregnancy weight. You don't just say that, oh, I have to eat because I'm breastfeeding, and then you're putting on all this weight. You can progress easily to diabetes. So it's important that mother continues to exercise and maintain the healthy lifestyle changes that they were doing during the pregnancy. And if at 6 weeks postpartum, what I would do if somebody see me for gestational diabetes is after delivery, 6 weeks postpartum, when they see the obstetrician, I would normally see them 3 months postpartum and do a hemoglobin A1C to see what is going on, if they have diabetes or not. I know these patients are at risk for diabetes, and so you should always be on the lookout for them. And then I always tell them that make sure that as part of your yearly physical with your primary, they screen for diabetes with a hemoglobin A1C, which is the 3-month average glucose control for diagnosing diabetes. Anything above 6.5 is considered diabetes. And then anything 5.7 to 6.4 is considered pre-diabetes. I hate using that word. And then less than 5.7 is normal. So we should know our numbers. We can go to the next screen. Thank you. It's all done.
Thank you. Thank you. This has been very informative. Dr. Eddie, I'm not sure if you have questions on your end or additional questions on your end for Dr. Fenn.
I think she has answered everyone's questions. So
She's
let
answered
me see.
everything.
Yeah, no question. People are
People
just
watching
being
and popping.
appreciative. Yeah. No question.
Okay.
Okay.
Well, this is a topic that affects everyone. It doesn't matter what race that you are, white, black, Asian, whatever, but it certainly affects multiple women. So we're very grateful that you were able to take the time to join us to have this discussion with our viewers. And we certainly plan on sharing the slides with them as well. So thank you. And we
You are
hope
very welcome.
we hope you're going to come back another time. See, I waited. We gave you 5 months, right?
Oh, that's nice.
I know it was 5 months. The last one was in December.
Okay.
So yeah, I am waiting, stretching it before I invite guests over here, so they don't feel like it's a repetitive thing.
Maybe next time we can talk about thyroid.
Yes. Well,
Yeah.
see, now I have a topic. We
Okay.
could, because a lot of people deal with that issue. So
Yes.
definitely we can
Mhm.
do that the next time you come. So thank you so much. Thank
Thank you.
you. And
Mhm.
and don't forget the list we gave you to
Absolutely. Absolutely.
to work
Absolutely.
to work on it for Dr. Eddie and I. I'm sure Auntie Jane is probably saying the same thing too. She mentioned it earlier. I spoke to her earlier. So we appreciate you asking folks about that as well.
Mhm.
So thank you. Thank
Thank
you.
you
So
for having
I'll be
me.
reaching out to you soon for
Okay.
thyroid.
Okay.
Okay. Have a wonderful evening.
You too. Take care. Bye bye.
Thank
All
you.
right, bye.
Bye bye. Okay, family. I hope that this discussion was beneficial to you and your family. As we mentioned, gestational diabetes is something that's preventable depending on your circumstance. So we do ask that you speak to your OB/GYN and your primary physician if you're a pregnant woman dealing with such issues. But as she indicated, as Dr. Finn indicated, a lot of it could be controlled with your diet. So certainly do consider that if you are planning to become pregnant. So thank you for watching our program. Feel free to submit any questions and concerns to us to emcunyourhealth@gmail.com. Again, that's emcunyourhealth@gmail.com. We'll love to hear from you. We certainly want to make sure that we are covering topics that is beneficial to you and your family, and not necessarily pulling things that we think may be interesting. So if you have a suggestion, feel free to reach out to myself, Dr. Eddie, or Auntie Jane Inti, and we'll certainly make sure that we find a specialist who is well versed in that topic to give a talk on it. So again, thank you for watching, and we do hope that you join us next time. And since we're still in a pandemic, please, please, please make sure you stay safe, wash your hands, social distance, wear your mask. I know there's a controversy about the whole mask thing, but you do know what the CDC said. So if you have been vaccinated, you can lay low with the mask, but that's not everyone's perspective. I still recommend that you wear your mask if it's your time to be vaccinated. We ask that you certainly do so because it can save your life as well as your loved one's life as well. So thank you again and have a wonderful evening. Bye bye.